Okay, that's
So,
fine. Yeah, no, I'm appreciative and respect obviously time. It is 2 o'clock, so I think in the interests of everyone's time and schedules, I think let's do that. I think yeah, Mariska is going to record it from her side, and then I think we just follow Jay the same sort of plan that we had on the afternoon. So Professor Richards to just set the scene, if I can say that, and then it's over to you.
yeah, thanks. We just
Okay,
had quite a few problems during the last session. You know, it went from, as I was explaining, Peter, from 22 minutes or 25 minutes to 22 minutes, and at the end was only 15 minutes. So it was more an organizational issue rather than panelists.
Yeah, thank you for that. Yeah, look, you know, the expectation is, I mean, once the discussion is over, it's over. But I think the expectation is to do something in the region of about 30 minutes. But if it doesn't go to 30 minutes and it's, you know, somewhere around there, so be it. You know, but unfortunately on the afternoon, it obviously got cut short as the conversation started to go. So Jay, it's totally in your hands. You call it when you feel the discussion's over. I think that would be great.
Yeah, I think we can jointly decide on that as we get towards
100%, exactly. Okay.
And like I said in between, you know, we edit out anything. So if there's comments wanting to pause, stop in between, we do that.
Yeah.
And we will just edit everything to have a nice flow at the end of the day. So
is there a hand showing of hand at the bottom if Damon or Martin want to say something?
Yes, you can. There's a reaction. It's a little face with a plus sign next to it that says reactions.
Yeah,
so you can either thumbs up or clapping, and then there's a chat box option as well, where you can communicate to each other in the chat box option.
Okay, that's fine.
If you also, Jay, if you click on the participants icon,
yeah,
you'll basically get a list of the participants, and then at the bottom is a raise hand, almost signal.
Yeah, yes. Okay, that's great. Okay,
so
that's fine.
Yeah, so you should be able to, if you keep that box open, you'll then be able to see if anybody puts their hand up to say something specific.
Could I make a suggestion that everyone who's not speaking mute their mics, or I don't know if you can do that?
Yeah, that's a good idea. Otherwise, you get interference.
Well, Mariska and I will obviously mute and hide our videos as well. Yes. But then, yeah, to your point, Professor Bezos, if you're not talking, to mute, and then when you do speak, to obviously unmute accordingly. That's a good idea. Yeah.
Okay. All right. So you're ready
Good.
to go. Thank you.
Thank you very much. Thanks. Thank you.
Well, thank you, Sanofi, for arranging this. This is a very apt subject. It's entitled Thromboembolism and COVID-19. We have a group of esteemed panelists today. Guy Richards will start off by giving us an overview of coagulopathy of the disease COVID-19. And then we will bring in the panelists, and I'm hoping to tie up some of the salient practical issues around thromboembolism, both in arterial disease and venous disease. The numbers in Johannesburg are now, I think, 130,000 in Gauteng province and rising. So we are the epicenter. And I'm told that KwaZulu-Natal is going to overtake us soon. So it's just a matter of time before you're faced with numerous patients that you're going to treat. And we hope to provide some insight into how you prophylax them and how you treat them. They do develop some form of active thrombosis process. So Guy, may you start? You can continue with your slides, and we'll then wait for you to complete before asking further questions.
Good, thanks, Jay. Just as you mentioned, an introduction really to the coagulopathy and some idea about the pathology or the pathogenesis of the process. So we know that there is a viral response phase initially, which is the early infection. Small number of people, 15%, go either onto the pulmonary phase or the hyperinflammatory phase thereafter. The latter two phases are the ones that cause so much problem and have people ending up in hospital. So you've either got a lower respiratory tract infection or the viremia itself, which initiates that hyperinflammatory phase that one has. The virus binds to the ACE receptor, the ACE2 receptor on endothelial cells. It promotes viral replication. There's an inflammatory cell infiltrate in response. You also get endothelial cell apoptosis and, importantly, microvascular thrombosis. And the microvascular endothelial injury with clot formation is consistent with a thrombotic microangiopathy, which occurs in addition to the systemic hypercoagulability, which is that about which one can do something, whereas the microangiopathy, it's a little bit more difficult to actually treat. So the SARS-2 virus invasion depends upon a specific protease, TMPRSS, which cleaves the viral spike protein. It then results in a dysregulated inflammatory response with increase in cytokines, and in particular IL-2 and IL-6. Those two cytokines bind to the endothelial receptors. They induce capillary leak, which is much the same pathology with all severe illnesses, that one gets capillary leak, and then induces the endothelial cells to secrete more IL-6 and other cytokines. And the coagulopathy occurs via complement activation and the membrane attack complexes on the endothelial cells, and then production of von Willebrand factor and factor VIII, and also plasminogen activator inhibitor from the endothelial cells. So that obviously the latter prevents the breakdown of clot. That's diagrammatically looking on the left-hand side, one sees a normal alveolar space. On the right-hand side, we see the disease state. There you can see little viruses that happen to be entering into the environment. They actually will then enter the cells, the alveolar epithelial cells. That then results in the production of these cytokines from the pro-inflammatory cells that you see here. You get vascular leak. The coagulation starts to occur with platelet clumping. D-dimers are then formed as some of that clot breaks down. You also then get production of more cytokines with inflammation into the systemic circulation. There we have another diagrammatic schema looking at some of the therapies that might be of value. There we have the virus. It binds to the ACE2 receptor. There is the virus itself. It requires this protease in order to be activated. Once that is activated, it starts to multiply and then will be expelled and infect more cells. IL-6 will be then produced in response to that. That results in the capillary leak that we mentioned earlier. You then get your procoagulant state from the membrane attack complex, increase von Willebrand factor, increased factor VIII, and then also increased plasminogen activator inhibitor. And all of those then result in the thrombosis that we actually see. One of the differences here is that we get microvascular coagulopathy. And one of the features is a diffuse pulmonary intravascular coagulopathy. This is DPIC as opposed to DIC, where you get marked microvascular thrombosis and hemorrhage with extensive alveolar and interstitial inflammation. And the key early features here are an increased D-dimer, which we see frequently from pulmonary vascular bed thrombosis and then fibrinolysis, but differs from DIC in that there's normal fibrinogen and normal platelet count. And you may even see elevated cardiac enzymes due to right ventricular strain from pulmonary arterial hypertension. As far as the macrovascular consequences are concerned, we see cerebrovascular events in young patients, myocardial ischemia, and micro and macro circulatory VTE. And the VTE rates in ICU are greater than historical rates, even with prophylaxis. One report found a 27% cumulative VTE incidence and another 11% at 7 days and 23% at 14 days. In COVID, ARDS versus a matched historic cohort, VTE incidence was 11% versus 2.1% in other patients with ARDS in ICU. And a French center found a cumulative incidence overall of 20.4% at 15 days, which is enormously high. And this has been mimicked by a study which came out today in JAMA, 3,334 patients. Thrombotic events occurred in 16%. It's around about the same amount in each case. 6.2% of those were venous, with 3.2% being pulmonary emboli and 3.9% DVT, and 11.1% arterial. Often people forget about the arterial manifestations. 1.6% of those were ischemic stroke, 8.9% MI, and 1% systemic thromboembolism elsewhere. The risk for that were age, sex, Hispanic ethnicity. We don't know about our race groups in this country. Coronary vascular disease, prior MI, or higher D-dimers. The all-cause mortality was 24.5%, and if you had a thrombotic event, 43% versus 21%. So it was independently on multivariate analysis associated with mortality, with an absolute hazard ratio of 1.82, and that occurred both for venous and for arterial as well, where arterial hazard ratio was higher at 1.99. So overall, a very high incidence in ICU in the study, 29.4% overall, in non-ICU, 11.5% overall. Antiviral effects of heparin may be important in terms of therapy. Past studies on SARS viruses found heparin reduced SARS-CoV-2 infectivity by 50%, and it may act as a non-specific polyanion blocking the charged spike protein from binding to the ACE2 receptor, or from cleavage of the S protein into activated components as well. In terms of evidence as far as therapy, 449 patients overall, and 99 received low molecular weight heparin. On multivariate analysis, D-dimer, prothrombin time and age were positively and platelet count negatively correlated with 28-day mortality. Low molecular weight heparin was only of benefit if you had more extensive thrombosis, and they used a sepsis-induced coagulopathy score in which greater than 4 indicated severe coagulopathy, and in that setting the mortality was 40% versus 64% in those who didn't have heparin, or if you had a D-dimer more than 6-fold of the upper limit of normal. It also reduced the hypercoagulability, inhibited IL-6 and its biological activity, and potentially blocked the cytokine storm. And just one other study that looked at overall patients on anticoagulation, whether oral, subcut, or IV, and adjusted for other comorbidities, 2,700 patients. In-hospital mortality was the same overall, anticoagulant, 22% and 22% in those that didn't have them. But in those on mechanical ventilation, in-hospital mortality was 29% versus 62% in those that didn't receive coagulation. And the longer coagulation that was administered, the mortality risk actually decreased as well, and bleeding events were overall similar. So that really is just a little bit of an introduction in terms of the extent of the coagulability and the problems one has in terms of dealing with this condition. You're muted, Jay.
Thank you, Guy. I assume you're done, so there are no more slides.
Yeah.
Just a few things to clarify. So we're dealing with a hypercoagulable state. I mean, that's obvious. Now, when we distinguish that from a DIC, in other words, that, or whatever you want to call it, the other name that you used, there is a in other words, this virus causes more a hypercoagulable state and a VTE rather than a DIC like Ebola and some of the others. So it doesn't pass on to that kind of viremic complication. Am I right?
Yes, so it actually is interesting because most of these patients, unless it's at the very late stage of the hyperinflammatory response, don't get a DIC. They get a DPIC, diffuse pulmonary intravascular coagulation, where the fibrinogen and the platelet count is normal. But that DPIC is associated with macrovascular coagulation as well, both arterial and venous. So, and that occurs without there being a DIC.
Yeah. So if we have to give an estimate of what the incidence is of VTE, let's just look at VTE, be it pulmonary or peripheral, and somebody admitted to an ICU, would you agree from your data that somewhere around 10 to 30%?
Somewhere around there.
Yeah.
Somewhere around there.
Yeah, now just thinking about the way people investigate VTE, would you say that this is underestimated to a large extent because some would be clinical, some would be based on D-dimer, so it could be far higher than this?
Yes, most of those studies that are looking at incidence actually actively looked for them, but some others are observational. in fact, because we know it's a hypercoagulable state, we anticoagulate patients anyway. So often that means that people are not looking for additional evidence of VTE because you are already anticoagulating. So perhaps that's why people are not looking as much as they should.
Okay, we'll come back to the ACE thing, I think, later. Let me just ask Damon, because he doesn't see vascular patients like Martin and myself who have thrombosis to start off with, and that may be a problem in terms of trying to interpret the D-dimer. Damon, from a general surgical perspective, so if you have somebody who's, let's say, needs a upper GIT operation, was found to be COVID positive, how do you deal with D-dimer? In other words, are you doing them routinely, and how do you interpret them from a general perspective?
So essentially at the moment, we're not doing many elective cases, whether they be COVID positive or negative. And even some of the COVID positive patients, for instance, for endoscopy, we're delaying. So we're not taking any particular extra precautions on patients that are being operated on for COVID. They would get their standard post-operative low molecular weight heparin. We have, certainly in the state sector, we have some difficulty in getting mechanical prophylaxis in any meaningful way. Whether we should be considering anticoagulating them more fully after the op, I'm not sure. Looking at the literature, I'm not sure that we've got anything that can help us with that. But so far, the patients that we've landed up doing as emergencies at Charlotte Maxeke, having laparotomies, we haven't seen the mortality rates that are reported in the literature of 20 and 40% of patients undergoing surgery who are COVID positive. We haven't done that many. There have been one or two that, in our opinion, would have died of their comorbidities. In any case, they were cancer patients with very poor outcomes at the best of times. So we haven't seen that huge surge in post-operative mortality in COVID positive patients.
Yeah, thank you, Damon. Martin, if I may bring you in. So D-dimers, from a vascular perspective, may point to pre-existing thrombus, like in an aneurysm or PVD. In this context, may also give an indication that you have impending COVID or worsening COVID. And then there's some information that it may even be prognostic towards severe COVID. Any comments?
Well, there are no comments. I mean, that's a remarkable observation, and maybe what one should really be doing is asking Guy what they do with that. I mean, so it appears to be part of the ongoing development of this intravascular thrombosis, hyperinflammatory environment, and if they do see raising D-dimer levels, do they do something about it, number one? But the other issue, Guy, that I find interesting is that there didn't appear to be any major difference between outcomes between people who were anticoagulated and not, and I wonder why, what you think the reason for that is. And then thirdly, if I may, just while we're at it, a lot of the early literature seemed to suggest that one would need to use multiple anticoagulants, and here particularly also thinking about the agents that look at platelet coagulation pathways, and wonder what your view about that is. I mean, it appears that this very much is a heparin level anticoagulation requirement, and that one doesn't get any additional benefit out of that. So I think, trying to unpack what the underlying pathology is around thrombosis may well be very interesting for the people we're chatting to.
So just to clarify, Martin, you're saying that we should use an antiplatelet agent together with.
And I'm asking the question because it doesn't appear to be part of the pathogenesis, and I think Guy's views on that would be very helpful to us.
Guy, you want to comment?
So yes, D-dimers definitely are prognosticating, and the higher the D-dimer level is, the higher the mortality. It's virtually a straight line in terms of that D-dimer. And in fact, the mortality is different. If you do have a D-dimer that is more than 6 times the upper limit of normal, and we actually see D-dimers of 15 and more, actually remarkable levels that elevate. then you definitely need to anticoagulate those patients fully. The point is, at where do you start the anticoagulation? Now, the American ACCP group, College of Chest Physicians, have put out that patients with normal or low normal D-dimers, or just within the normal range, should not be fully anticoagulated. And that probably is correct. The point is, though, that of all those patients that we admit to hospital, they all have the pneumonic infiltrate. And with that pneumonic infiltrate, their CRPs are very high and their D-dimers are high. So we actually then fully anticoagulate patients who are admitted to hospital. Patients who have the disease, who are at home, then we suggest that they remain on some form of prophylactic anticoagulation, like a NOAC or Clexane, to be taken at home, because we've seen a number of patients arriving, well, not even arriving, dying at home because of thrombotic events, even though their D-dimers weren't all that high. So in hospital, we're anticoagulating them fully. In terms of the platelet, well, that's an interesting one, because there was a physician from Stellenbosch who put out a video that virtually everybody in the country saw, saying that it's easy to treat this disease. You just give them a full anticoagulation and 3 antiplatelet drugs, which was a little bit nerve-wracking in terms of some people doing that, because even the combination, as you know, of aspirin and full anticoagulation has a risk with GRT bleeds, and then we're going to send them all to Damon so he can deal with them subsequently. What we found is that if you still are clotting despite being on full anticoagulation, we ask our anesthetist to come and do a TEG for us. If on the TEG, your maximum amplitude, in other words, the clotting that occurs on that, if that's still normal, then we may well add an antiplatelet agent. But do remember that your bleeding risk increases exponentially the more anticoagulant agents that you happen to be using.
Thank you, Guy. Just to clarify what you're saying, because you made an important comment regarding the prophylaxis at home. So COVID is divided into mild, moderate, severe, perhaps critical disease. So are you saying that perhaps moderate disease at home, some moderate in terms of symptoms can be treated at home, would get, let's say, enoxaparin 40 daily for a period, and then the critical severe with you would get a double dose in full anticoagulation? Are you tending to suggest that the mild, perhaps less severe forms of it, mild upper respiratory tract at home, would you then suggest they get anything, or perhaps do a D-dimer to see whether it's climbing, like a pre-COVID situation, and then give them something, or not?
Well, I think it really does depend upon the D-dimer. If you're being treated at home and you are requiring oxygen, some patients are treating themselves at home with oxygen. Almost all of those patients have very elevated D-dimers, in which case I would recommend full anticoagulation in that setting as well, with either a NOAC or with Clexane. I'm happier to use the enoxaparin or a heparin of one type or another, because there is some evidence that the heparin might have antiviral activity in itself. So that is a possible benefit specifically of the heparin, whichever one you used, a fractionated or an unfractionated heparin. If you're at home and you have a low D-dimer, there's no good evidence that at that point taking an anticoagulant is of worthwhile if you're up and about and mobile. If you're in bed and lying and not moving around, then quite possibly you should be taking some form of prophylaxis.
Yeah, I think the point is that should we be almost routinely doing some sort of biomarker when you COVID positive? In other words, whether you're symptomatic or not, which will point you into some direction.
Definitely.
Yeah.
Definitely. I think that D-dimer, along with the C-reactive protein, and your ferritins and your LDH and your lymphocyte count are all critical initial investigations that you should be doing. And really, you should be doing them daily.
Yeah. bit of a costly exercise, but nonetheless, it's what we need. Just, Damon, is there anything else you want to comment on in terms of bleeding? Because during the last symposium, we had quite a nice brief. Let's start there.
So Jay, I've got one question, and I'm not sure if it was answered or not, regarding people who are already anticoagulated for other reasons. Now, obviously, they've got some comorbidity, but what is the evidence about their outcomes? So patients who arrive at hospital either on warfarin, NOAC, or some antiplatelet anticoagulation or antiplatelet therapy, what are their outcomes? But whilst guys thinking about that, what's strange in a way is that the number of endoscopies being done for GI bleeding around the world has decreased quite exponentially. There's been a study from Italy, a study from New York, where they showed that the number of scopes done for bleeding came down compared to the few months before, and also compared to corresponding months the year before. And it might be that people are just not pitching up with and having minor bleeds at home. The Italian study showed that those patients who did have scopes had more chance of requiring some sort of endoscopic therapy, but it wasn't a huge percentage, it was sort of 8% more, but it was statistically significant. Last time Guy and I chatted, he felt that there wasn't a huge number of patients in the ICU bleeding from the GI, despite them being anticoagulated, and that if they were bleeding, providing they were stable, we wouldn't do anything about it. We would just keep them on a PPI and keep them fully anticoagulated, and only scope them if they were COVID positive and they became unstable or they required ongoing transfusions. So although lots and lots of people are being fully anticoagulated and are sick, somehow the GI physicians around the world are not seeing huge numbers of excess GI bleeds in these ICU patients.
I think that probably is true, Damon, that that we haven't seen very many bleeds, although there was one study which came out, I think it was also from Italy, which said that they had a bleeding incidence of 10%, which was high, but we haven't really seen that. The one I remember bleeding in particular actually had angiodysplasia and bled from something that was a different site that was usually the site that people would bleed from. In terms of patients who are already on anticoagulants, well, I don't know the answer to that, whether they have a better outcome or whether they have a worse outcome. I think that it's only one factor, however, in the determination of mortality. And I think that the pulmonary manifestations are the primary ones, although it is true that clotting contributes to an extent to that as well. I haven't seen a study in terms of people who have been on anticoagulants beforehand and in terms of what their outcome is.
Thanks, Guy. Just to follow up on that. So if you have a patient and you are therapeutically treating them in ICU and if they recover, bearing in mind that we're looking at some sort of thrombotic mechanism in the lung, so it's not a pulmonary embolus that we're talking about, how do you manage their post-discharge anticoagulation?
Interestingly, it can also be, of course, a pulmonary embolus. And I was consulted yesterday about a patient in private who had a major pulmonary embolus and who was administered a thrombolytic agent and immediately improved the gases. When I say immediately, within a couple of hours, improved their gas exchange dramatically. So one always has to try and bear in mind that that might exist as well. In terms of discharging patients, we're recommending anticoagulation for at least 2 weeks afterwards. And if the D-dimer is still elevated, we would recommend continuing for longer. But if you're mobile, D-dimers return to normal, 2 weeks is probably an adequate period of time. Something like the orthopods.
Yeah, good advice. So I think we monitor the D-dimer. I think that's, I'm just going to bring Martin into something that's a little bit different. So we have seen that our mortality rate in South Africa generally is lower than other parts of the world, given the numbers that we see. So considering the viral attack rate versus the death rate. Do you think that there's a specific reason for that, Martin, in terms of the aged population, or do you think there's something else that may be contributing to relatively low, well, at this stage anyway, low mortality over the numbers? So now I checked yesterday, we are number 5 in the world in terms of numbers, over 300,000. When you compare us to Italy, Spain, even Germany, our death rate is way down, bordering on less than 1%.
So Jay, I mean, our mortality rate, case mortality rate is closer to 1.5%, which acceptably is still low. But I think that there are a number of areas that we need to think about before we think that it is a low number. So one of the issues obviously is the issue in terms of reporting those patients who've been infected by the coronavirus and who have died from it. And there may well be a significant underreporting. If we look at the excess mortality in the country, that is ahead of the reported numbers of cases that have been considered to have died as a result of the coronavirus infection. But I do think that there are probably going to be other factors that we need to still take into consideration in terms of our numbers. I mean, again, we are relatively early in this very rapid phase of increases, and I suspect we are going to do a catch-up. I'm sure that Guy will indicate that while there are people who die early from the disease, the major mortality rates are really 10 days post and beyond that. So I think we're going to have to wait a little bit of time, and we may well still be in a catch-up phase. But then there is no question that we have a younger population. The median age in South Africa is at the moment somewhere in the region of 28 years, which is obviously substantially less than what one has in other parts of the world. And we do know that it has been largely affecting an elderly population. One of the more interesting things that has been talked about recently was the whole issue in terms of the ACE2 receptor. And Guy, again, a view, I mean, we know that ACE2 receptors are increase as we get older, and particularly in the pulmonary and nasopharyngeal environment. And it may well mean that those people become then, because of the central component of the ACE2 receptor, both in terms of the virus, but also to some of the complications. And I think what has become really quite interesting, that thrombotic complications seem to be associated with the ACE2 receptor as well. So I think that those are, we probably too early to really be too clear about it, but there may well be some reasons in the background. If I may just, Jay, while I'm talking, I do think that, Guy, the centrality of hypoxia in this whole situation. So on the one hand, we recognize that the thrombosis is probably one of the reasons that there is this associated hypoxia, but the hypoxia in itself is known to increase thrombotic risk. Is there something here that one needs to be looking at, and in particular in terms of the treatment of these people? We talk about the happy hypoxic with SATs of 50, but if there's a person who's got a thrombosis or is very clear, has got very high D-dimer levels, is that something that you would then want to kind of address particularly?
Well, that's an interesting point. Just in terms of the overall mortality, I think that one of the reasons why Gauteng has been lower is also because of the fact that we have the highest concentration of ICU beds in the country. Which means that certainly in our private situation, the private hospitals are as full as the public hospitals, and people have access then to that sort of care. If the numbers keep increasing, of course, then this becomes more and more of a problem. Just one other factor is that we developed protocols way back in early March that included things like corticosteroids and full anticoagulation, which wasn't incorporated in many of the other provinces until later. And I think that may well also have made a difference, certainly in terms of Gauteng. But I do agree with you that I'm almost certain that we're going to start seeing these increase as the numbers actually increase. As far as hypoxemia is concerned, well, that's true. And we do aim our therapy initially, other than pharmacotherapy, at improving oxygenation, and start with nasal cannula, then go on to high flow nasal and CPAP, and try to avoid mechanical ventilation if we possibly can. Most patients will actually settle on that as well and don't require to go onto ventilation. One of the reasons why the mortality is higher on mechanical ventilation is because it's only the very sickest patients who haven't responded to any other form of therapy that end up on mechanical ventilation. So, yeah, I mean, treating the hypoxemia is critical.
Thanks, Guy. Just to go back to the ACE receptor issue, I mean, it's just not age that increases the numbers and sensitivity, the other disease processes. Do you want to comment on that?
Yes, well, one of the important factors or worries was that if you were on an ACE inhibitor or an ARB, that they have been shown to increase the ACE2 receptor, and maybe you might be worse off. But in fact, that's really been disproved and is not the case. And it's recommended that people requiring an ACE or an ARB should actually remain on them. There also appear to be genetic differences in terms of ACE receptor number. And that might also have some sort of an impact on the outcome as well. I also believe that there are nutritional deficiencies that are common to people who have risks, and that means diabetics, it means hypertensives, it means obese patients, etc. And those specifically relate to nicotinic acid or niacin, which in combination with zinc activates a molecule called SIRT1. And SIRT1 is an innate immune modulator. It decreases cytokine formation. So whereas that's unproven, I did publish a paper on that in Medical Hypotheses. I think it has some possible rationale in terms of improving outcome if you utilize those as well.
Thanks. Just to shift a little bit, we talked about extended prophylaxis or extended therapy of some sort when patients are discharged. Based on your comments about heparin and its protective or beneficial effect, would you then always suggest that these patients get an injectable, in other words, some form of heparin rather than an oral agent when discharged? And will there be benefit, or are we just hypothesizing?
Just a hypothesis, and many patients find it too difficult to actually inject themselves. So maybe in those circumstances, I would prefer that they use something like, at least like a DOAC or NOAC, rather than using nothing at all. Some patients are using aspirin alone as well. And that may also have value in terms of both the venous and the arterial side.
Okay, I think we've got a few minutes. I just want to touch on the issue around HIV, which the world thought was going to be an absolute problem when COVID reaches our shores, but doesn't seem to be the problem for now. How prevalent is it? What are the risk groups, etc., and how would you treat them with anticoagulants? Now we have almost a double hypercoagulable condition. Any comments?
So yes, the Cape Town group suggested that having HIV and TB, well, that of course is a third risk for coagulation, increases the mortality, and that more patients who have HIV were percentage-wise relative to the population were actually being admitted. In our first 100 patients, which has just been published in the Wits Journal, we only showed an incidence of about 6% of HIV positive patients, whereas our total population in the community is probably 8%. So, and they also, by the way, none of those patients died, of those HIV positive patients. So we are not seeing what Cape Town seems to have been seeing in terms of there being a greater risk with HIV positive patients. But we would also anticoagulate those patients early because of the risk of coagulopathy. it doesn't surprise me that much that the HIV group might not do that badly, because remember that the mortality occurs in the inflammatory phases of the disease, like the mnemonic phase and the hyperinflammatory cytokine production phase as well. And if they are relatively immunocompromised, they might not be able to produce the cytokines in the number and the amount necessary to cause those abnormalities. And interestingly, that's been seen also in rheumatology patients on biologics, and also in oncology patients who haven't been overrepresented in the numbers getting the disease.
Yeah, that's interesting. I suppose we've got to wait for more data on HIV. There's a whole host of patients who are HIV positive who are not on antiretrovirals, and that may be another group on its own that's a particular risk. I don't know if there's anything else. Does anybody from Sanofi want us to discuss anything else in particular, or Martin?
Just to
Damon?
mention that Truvada also has been shown in one study. Patients using Truvada were less likely to have severe manifestations of this disease. So some antiretroviral combinations might also make a difference in terms of therapy.
And that's a cytokine storm effect. You think that's where it's
I think it suppresses the viremia, because when you develop the actual systemic viremia, at that point, that's when you increase your cytokines dramatically, which is why I'm actually quite interested in seeing how remdesivir will help, because remdesivir is an antiviral agent. And in many circumstances, we treat a disease with both some specific therapy and with corticosteroid. So if you get pneumocystis, we'll give you Bactrim and we'll give you a corticosteroid. TB in the ICU, we give you corticosteroid and TB treatment. Meningitis, we give you corticosteroid, etc. So it's quite possible that if you could use both corticosteroid and an antiviral agent that works, that we might see better outcomes as well.
I didn't go through that paper in any detail, that randomized control study. I don't know whether it's available on dexamethasone. I don't know if the actual paper, I mean, I've read the abstract, but are you using dexamethasone almost routinely now for inpatients?
Well, not necessarily dexamethasone. We'll use corticosteroid because we believe it's a class effect. So long as you're using low-dose corticosteroid and you are only using it in those patients who already have an inflammatory response. In other words, their C-reactive protein is elevated and they're hypoxemic. If you use it in the upper respiratory tract phase, oral steroids will increase the potential for the viremia and make you worse off. And that's one of the big problems out there is that in the community is that people are going to their doctors and saying, I want dexamethasone. But that is incredibly dangerous in the setting of a patient who's not having an inflammatory response.
Yeah, correct. Is there anything else, Martin?
Yeah, so Jay, just one question. I mean, so one thing that we have not seen in the WHO sponsored study is that the Truvada combination has been taken off as an arm and seems not to have had the effect, but the remdesivir arm still continues to be an important one. But Guy, early on you mentioned using the biologics, anti-inflammatory biologics as a potential, and would that have an effect on the thrombotic issues?
Well, I haven't seen anything on it having an effect on the thrombotic episodes, but there are now all sorts of biologics which are being tried and in many circumstances showing positive results. We don't as yet have a randomized controlled trial, although the recovery study, which did the Dex one and the hydrochloroquine one, is currently ongoing and will certainly come out. That's looking at tocilizumab, the anti-IL-6 agent that's used in rheumatoid arthritis. Now, we recommend that that be used only in patients who already have failed anticoagulation and corticosteroid, and despite that have gone on to elevate their CRPs and to develop worsening respiratory failure. So in that category of patients, we then give them a dose of tocilizumab and have had seen some quite spectacular results, but it's certainly not everybody. And like all of these drugs, including DEX, it decreases the mortality rate, but it doesn't remove the mortality. And that's important for people to realize.
And Guy, then the use of inhaled steroids?
Well, I mean, that's also an interesting one. I mean, that's some time ago, there was evidence that the inhaled steroid ciclesonide, which is used in asthma, was beneficial and had an antiviral effect. And recently, a very small study has been looking at budesonide, another inhaled steroid, that may well have benefit as well. Why precisely they have benefit when used in inhalation in the early phase as opposed to oral steroids is a little bit difficult to say. But I think we need a randomized controlled trial there too, but that may well be another option in terms of decreasing the pulmonary manifestations of this disease.
Yeah, I think, how much is tocilizumab?
It's about 6,000 Rand, which, you know, it's expensive, but nowadays, if you look at the cost of antibiotics, for example, I mean, you know, you can use that in 2 or 3 days using broad spectrum newer antibiotic agents.
I think perhaps we should just ask one more question, which we haven't discussed, which is, I think, important. So we talked about low molecular weight heparin, and NOACs, but surely in our population, warfarin is going to have an important role, just in terms of costs, etc. So how are you monitoring it? If you send them home, I assume you do. Or is just
well, in fact, from our point of view, in our hospital, we send patients home on enoxaparin, not on warfarin, because we do have access to that and have had access to that for home use in terms of patients post-hip or post-knee replacements. So that's what we've been using. We haven't as yet used warfarin, and we've just approved a buyout for DOAC for 3 months to cover us during this period of time should people need some oral therapy instead of using the enoxaparin.
That's interesting. Damon, comments?
Yeah, so I just think that I'd like to come back, if possible, to the management of patients at home, and especially young fit patients who get minimal symptoms. You know, I know that, for instance, in the UK, if you think you got COVID, they actually don't want you anywhere near the hospital. Now, to suggest that patients who've been treated at home should go for multiple blood tests and or start taking injectable anticoagulants, I'm just not sure of the feasibility of that, even in a very well-resourced country. So maybe, Guy, I think we just need to clear this up, because there are going to be a lot of people listening to this to say, well, everyone at home now almost has to take one. I don't think it's going to be feasible for patients to get daily blood tests to look at their CRP and D-dimers at home. So would you only then reserve that for people who are at risk or people who are very symptomatic, that they should go get these blood tests? Because even going to get a blood test when you're COVID positive is not an easy thing.
So, I mean, that's a very good point, and you're completely correct from that point of view. Your young fit patient who has been diagnosed as COVID is generally sent home with, if possible, some measure of oxygenation rather than doing repetitive blood tests. So if there is access to an oximeter, well, then that would be good. Otherwise, if you become short of breath at all, then it would be critical for you to come to hospital and then to have those measurements. But you're quite right. The vast majority of people, 85%, are asymptomatic or have mild disease. And it really wouldn't be practical to do it in every single patient. So at-risk people and people who de novo have very elevated C-reactive proteins and or are hypoxic on diagnosis.
Yeah, does anybody from Sanofi want to make a comment? Peter, are you there?
Yes, I'm here. No comment from our side. I think it's
Are there
really
any questions you think we should raise? Any other points?
nothing that I can think of specifically. I think a lot of it.
Well,
has
maybe
been
if we've got 2 minutes,
controversy.
I think perhaps what we should just ask. I mean, it's more for general surgeons, I suppose, who are going to request it. dangers of IVC filters. I mean, we've seen a few put into COVID patients, and I can't figure out why, and they usually cause problems. But filters are a coagulation problem in their own right. You know, so if Martin wants to comment, or Guy, should we have a very high threshold to consider these in the face of pulmonary emboli? Or should we not be using them at all, because you're looking at hypercoagulability plus the issue around placing a foreign body in somebody who's sick? Martin?
I think Martin should answer first, but I'm just going to mention one, that we had one situation that I was consulted on where a patient had been on ECMO, and on insertion of the ECMO, they had perforated the iliac vein. And now the patient also had a deep vein thrombosis on the same side as a leaking perforation in that iliac vein. And the suggestion was that they should put a filter in there. And I actually said no. They tried to fix, and successfully did fix the leak, and anticoagulated thereafter, and the patient did well. But I'm scared of them. Sorry, Martin.
I think that we all agree with you. I mean, despite the fact that we're supposedly the people who should be putting these in, we generally are very careful. Jay, I think as a broad guideline, I think one should continue with what one normally would do. I mean, I wouldn't say, you know, don't place an IVC filter, you know, under any circumstances. But what we need to recognize is that the thrombosis is not an isolated thrombosis that you have in the leg that you can protect. It's a generalized thrombosis. And it's not a way of protecting the patient against anticoagulation. So anticoagulation is the first treatment. And I guess a second form of anticoagulation is number 2. And it's only when you really have some really unusual environment that I would think that it may well be indicated. But therefore, you know, don't say no, but it's, you know, we have to ensure that patients are anticoagulated.
Sure, thanks, Martin. And I suppose you need a good radiologist. You must distinguish between pulmonary emboli, proper pulmonary emboli, and other forms of thrombosis in the lung related to COVID, because if you can't do that, then it's
but it sounds like that what is happening is you might have the pulmonary embolus anyway, but on top of that, you've still got intrapulmonary small vessel thrombosis. So you're going to have to anticoagulate. And if anything, it sounds like one should be looking at thrombolytics as something. If this is what the issue is, then that one's looking at a mechanical device that would stop you from being able to do all the other things you want to do.
Yeah, just in terms of Guy's patients, the torn, what was it, iliac vein?
Yes.
They've created their own IVC filter, because when you repair it, you'll ensure that it blocks off at that level. So it's,
well, they used a gel, so whether that blocks it off or not, I don't know.
Okay. If there's anything else, then Peter, maybe adjourn.
Absolutely. Yeah, just from my side, once again, thank you so much. I think you've raised some really, challenging questions, and I'm sure the audience will gain a lot of benefits. So thank you.
Thank you very much, all of you.
Thank you. And Peter, may I just, Wit's biennial has been completed, but in behalf of the Department of Surgery, may I thank you and Sanofi again for being really central to ensuring that kind of symposium happens timelessly every second year. Thank you.
Yeah, I'm glad that we're able to actually go ahead. You know, so many conferences have been disrupted. So hats off to the department for actually pulling off the meeting, doing it virtually. I think it was quite innovative, and it was at least a good thing that we could actually do the meeting. So thank you.
Thanks.
And it's been many years that we've been associated with that meeting. So hopefully it continues.
So Peter, many years is a little bit of an understatement. I mean,
yeah, I think it's many years.
And certainly the association with enoxaparin in its various forms, but particularly Clexane, certainly from the early 90s. So, we're really heading towards a very long association.
Absolutely. The drug now, I think, has been available in South Africa. I think it's either 27 or 28 years. I know a few years back now. So I think it was 3 years back. We celebrated almost 25 years on the South African market. So I think this year is year 28. you know,
Well,
and
well, I can give you the exact date. You know, so I returned back from the UK in 1991. So that was in September 1991, and very soon thereafter it was. So it must have been in 1992.
yeah, so that would make it 27, 28 years, 100%. So good.
Right, guys, thanks a
you
lot.
Very much.
Have a good afternoon, and thank you. Thank you for the work you're doing on behalf of the South African population. You know, you guys are in the front lines. So from Sanofi side, thank you for all of that.
Keep well, guys.
Great. Thank you. Keep well.
Thank you. Bye-bye.
Thanks, Mariska.
Thank you, everybody. Bye-bye. Thank you.